Okay, can you hear? Oh, that's better. Hello and welcome, everyone. I am just so excited to see so many of you here today. I have to tell you, this is the first public event at the Monterey Center since March 2020. So, hooray! And I am so excited that our very first public event is a speakers forum and on a topic that is so timely and so important to each and every one of us. And I'm very pleased to welcome Camille Currie and all of her colleagues from BC Healthcare Matters, who are going to enlighten us about the petition, the May 19th rally, and other issues dealing with healthcare in our province. So, should I give the microphone first to Alexis? Yeah. Alexis Reid, everyone.
Hello. How's that? Is that good? Sorry. Hello, my name is Alexis. I will be your MC this afternoon. I'm the project lead at BC Healthcare Matters. Camille calls me her second in command. We're here today to discuss the primary care crisis. Today, Camille, Sharman, Jennifer, and Lana will share their experience with the primary care system in British Columbia. We hope that you leave this meeting with a better understanding of this crisis in healthcare and what we as advocates hope to do about it. So today, what we'll do is we'll start with the speaker portion of the session. So I will speak a little bit, Camille will speak, Sharman, Lana, and Jennifer will speak for the first hour, and then around the first hour, and then the second half we'll reserve for questions. So I'm sure you'll have a lot of questions that will come up as we talk. So just hang on to them until the end and we'll get to them. If we can't answer any questions that you have, we'll write them down and we'll make sure to get back to you as soon as we can in the coming days. So none of us would be here today if it wasn't for our first speaker, Camille. When Camille started BC Healthcare Matters, she showed us all how powerful the decisions and actions of one person can be. She showed us that one person can make a difference. She also showed us how powerful the collective voice of the residents of British Columbia can be. Camille is the founder of BC Healthcare Matters. She's also a devoted parent, spouse, and business owner. In January, Camille jumped to action when she saw the healthcare in British Columbia needed serious change. It is that drive for change that led her this past January to start BC Healthcare Matters, including its website and petition. Its website and Facebook page. She didn't stop there. She started a petition to the BC government demanding that they deal with the doctor shortage in British Columbia. That petition now has over 32,000 signatures. And of course, she didn't stop there. She stood in front of every reporter and newscaster who would listen to ring the alarm bell about this crisis. You may have seen her in every single media format, or on the radio, newspaper, everywhere. And still she hasn't stopped. Surrounded by her team, like me and Sharman and Lana and Jennifer, she has now set the scene for a province-wide call to action May 19th with a rally at the Legislative Grounds in Victoria between 11 and 1 p.m. That's May 19th from 11 to 1 at the legislature. So now I will pass the meeting over to Camille, and she will discuss more about the primary care crisis in BC.
Perfect. Thank you very much, Alexis. I am so glad to see so many of you here today, and I'm also grateful for those that are joining us virtually today. You actually make Camille a little emotional. It is personal. but it's beyond personal. It's about my desire to be able to seek out better for all of BC. All of us need a healthcare system that is willing to support us and provide our best quality of life. And we don't have that right now. We all know that. So, as a little background, I got into this because I was one of the 1 million in January, or joined the 1 million in January, that found out that my family doctor would be leaving and that we would be without a family doctor. You may have heard some of the parts of the story about our family. I'll highlight just a couple parts that really are what make this a struggle for us and what make this situation difficult and why a family doctor is so important for people. For our family, we have 2 children and my husband that have a very rare gene mutation that is disease-causing. There's nobody else in the world alive right now with the same gene mutation as them. We don't have any records or any files to dictate for us how their life is going to go. They've had a number of struggles, each of them already in their lifetimes. And we need a family doctor that's willing to support us, follow us through their journey, through their growth, and ensure that they get the best quality of life possible for them. I myself have several different conditions, one of which is, that some of you here may also have, I have a pacemaker. I had it implanted at a fairly young age when I was 31 years old after a couple heart surgeries that left me with minimal function left. My pacemaker runs me about 70 to 90% of the time in both the top and bottom of my heart, so I'm very dependent on it. In January, when we found out that we were losing our family doctor, it became even more alarming because we realized that my pacemaker battery is running out. I have less than 10 months left on it, and when I went to see my cardiologist and informed him that I no longer had a family doctor, his advice was, trust the system, Camille. Trust the system that will provide for you. Don't worry about the questions that you have, and we will contact you when it's your time. I don't trust the system. When my family can't get a family doctor, I don't trust the system. When I'm left to decide how much of my arrhythmia medication or blood pressure medication I should take each day, I don't trust the system. When we hear of hospitals overloaded and the government seeking out renting hotel rooms for patients, I don't trust the system. It is not providing for us. This is a national issue. We have healthcare problems across Canada. BC has every province has their own reasons for why they're facing their own crisis. BC has the worst ratio, though, of unattached patients of all the provinces. Latest stats suggest that 5 million citizens across Canada do not have a family doctor. 1 million of those 5 million reside in British Columbia. We happen to have, and one of the differences in British Columbia compared to other provinces is that we happen to in fact have enough trained family physicians in our province to care for our entire province. We have 6,800 registered family physician licenses currently in British Columbia. We only have 3,100 of them practicing as family physicians. So we aren't missing the bodies, we aren't missing the infrastructure, we are missing the support to utilize the trained individuals in our community. Many of you have heard the discussions that have taken place surrounding urgent primary care centers and their role in this crisis and their role over the last 2 NDP terms. Most UPCCs have not been able to staff properly. This is one of the major problems with the urgent care centers right now. They are not a solution to the crisis when they cannot staff them. And yet, we spend $2 to $5 million every time one of these urgent primary care centers is built and created. Taxpayer money. There are inefficiencies in these centers that make it more difficult for nurses and family physicians to do the job that they want to do. For example, Abbotsford Urgent Primary Care Center, where their annual budget is $4 million, only sees an average of 18 patients a day. If we follow those numbers, that suggests that the Abbotsford cost per patient is approximately 232 taxpayer dollars every time someone is seen there. In contrast to private practices, where taxpayers pay the $31 fee. This data has been provided by someone who has had a role in this center. We haven't been able to fully fact check it at this time, but how are we to fact check it when the provincial government has delayed all of our requests for freedom of information to outline the costs and the expenditures of the urgent primary care centers in British Columbia? This leads to my next concern with the urgent primary care centers, which is that there are efforts being made to conceal the data. This is an ongoing issue of transparency with this government, and we hope to continue to highlight that. We as taxpayers deserve to know where our dollars are going and how they are being used, and whether they are being used in the most efficient manner possible to care for us. You've obviously probably heard of the waits. The last point about urgent primary care centers is, I do not agree with individuals having to line up at an urgent primary care center at 7 a.m. just to be able to see a doctor. And that is only if they actually make it to the door before they close the door and are at capacity. This is not a situation that helps provide for our elderly, our disabled, our young. This is not a situation that is providing primary care to the citizens of British Columbia. From my perspective, the government seems to be making a real push to intentionally remove the family physician from primary care. We see news reports about new medical center infrastructures that are supposedly the answer, but we are in a crisis state right now. We can't wait for infrastructure to be the answer. Furthermore, why do we need the infrastructure? We have the clinics established, the infrastructure is here, the bodies are here, but where's the support? I've been asked lately when I've done some interviews why I think this is happening. This is happening because the rates of pay are not keeping up with inflation or the shift in what is required within the scope of a family practitioner's job. BC family physicians are the lowest paid family physicians in all of Canada. Next to them is those that work in Nova Scotia, who earn $20,000 more. I believe the second issue that we face is a lack of collaboration with the BC government. This is a huge problem. The government and the medical associations need to be able to come together to be heard, to be listened to, and to work together to achieve a supportive system. This has not been happening in BC for a very long time. The Health Ministry of BC continues to refuse to admit that their plan for reforming the BC primary care system is not working. And not only that, but it is driving our physicians away from family practice at an alarming rate. When I'm asked on interviews what I think that the short-term solutions could be, my answer to that is, there are no short-term solutions. Short-term solutions are band-aids, and we don't need them. What we need is action, and immediate action. We need the government to be ready to come to the negotiation table in the immediate future. We need the government covering a similar portion of overhead for family physicians as they do for nurse practitioners, which averages between $75,000 to $85,000 in overhead for nurse practitioners. They also need to acknowledge the time commitment that longitudinal care requires and implement what are called time modifiers to allow family physicians to bill for the extra time that they need to support you, to provide for you, to ensure that your tests are being reviewed, that the next tests are being ordered, and that they can feel they are being recognized and valued. In turn, I feel that if those actions were taken, we would see true stabilization of our system, and we would be able to attract new family physicians. You might then be asking yourself, where's the money going to come from, Camille? And my answer to that is, when there is a will, there is a way. We want transparency. We want clarity about where the funding from our health ministry is going. We want to be able to have a say in whether building 24 more urgent primary care centers at the equivalent of $3 to $5 million per building is efficient use of our healthcare money. That is all I have for you today. I am so grateful that you have all come to join me. I'm so grateful that you've signed the petition, and I really look forward to seeing you all on May 19th.
Thank you so much, Camille. So, our next speaker today is a dedicated volunteer with BC Healthcare Matters. She works tirelessly to promote our campaign in the community. Sharman's passion comes from her own experience with our struggling healthcare system here in Victoria. Sharman will now read a personal story with us that was shared by one of our supporters who has been personally affected by this crisis. This story will illustrate how vital it is for us all to show our support for primary care in this province by signing our petition. We do have a petition signing sheet over here. We have ways for you to sign online. Thank you.
Thank you, Alexis. Can everybody hear me? Yes. I'm so glad you all came. I've been tasked with reading some of the stories that get sent to Camille on the website and on the Facebook page, and some of them are truly sad. Some of them are quite enlightening. The first one that I'm going to read is from a specialist. I'm a specialist in rheumatology. The shortage has caused an increase in anxiety in my patients who have no family physician. They become desperate and require longer and more frequent visits for reassurance and management of primary care issues such as essential hypertension, diabetes, pain, and sleep problems. With the desperation, they become anxious, irritable, and often rude out of frustration. In one scenario, I had to prescribe an antidepressant for a young man with lupus. I've also seen an increase in inappropriate referrals from walk-in clinics, some of them who had virtual appointments. They have not even examined the patient, and also from nurse practitioners who don't have the same scope of knowledge as a family physician. This is resulting in longer wait times in my specialty, rheumatology. I've seen negative outcomes, including avoidable hospitalization and vision loss, brackets blindness, and significant joint damage due to delayed presentation and referral. For example, a 21-year-old who should have been seen in less than 6 weeks and would have required only mild medications presented 6 months later with severe uncontrolled disease and joint damage that she will have to manage lifelong and now requires potent and very expensive immunosuppressants. This could all have been avoided. One of my patients was diagnosed with cancer in the ER and had no family practitioner to support him through the system. He died early, but would have possibly qualified for immunotherapy to extend his life had he had a family physician to see when he first became unwell. I have seen duplication of labs inappropriately by different walk-in clinics. All of this comes at a huge cost to the system and to society. My family medicine colleagues are closing their longitudinal care practices because the cost of overhead is too high. Indeed, most of them take home less than a nurse practitioner once you factor in a family practitioner's overhead costs. Pay family physicians a fair remuneration. The insanity has to stop.
Thank you so much for that story, Sharman. So our next speaker today is Dr. Jennifer Lush. Jennifer is a happily married mother of 2 boys and a family physician who was born and raised in Victoria, British Columbia. She first decided on a career in medicine at the age of 5 and has practiced family medicine for the past 20 years, primarily in British Columbia. although she also practiced in Alberta and Australia. She feels incredibly privileged to be involved in the care of her patients. Today, Dr. Lush will share about the importance of family medicine, as well as her own experience working as a family physician during this crisis.
Thank you. Can everyone hear me? I'm a bit. Maybe you can. Is that better?
That's a good compliment.
Thank you, Alexis, for the introduction, and thank you to Monterey Center for agreeing to host this event to shine a light on the family doctor crisis in BC. Crisis is a pretty strong word, isn't it? Mm-hmm. But it is definitely the appropriate word to use to describe what we are currently experiencing in BC. Family medicine in BC in its current form is simply unsustainable, and we need changes to be made now to keep the few remaining family doctors we have in practice. Why is family medicine so unsustainable? Most of us are caring far more patients than we should. Since I am a mom of relatively young kids, I took on what is considered a part-time practice, yet I carry almost 1,200 patients and not infrequently will work 60 to 70 hours a week. Much of that work is done after hours. The minute I tuck my kids in bed, my computer comes out and I chart until, almost always till midnight and frequently until 2 or 3 a.m. Every single night, weekends included. And because I'm not in front of a patient, none of those late night hours are paid. What keeps me up so late? The amount of paperwork expected has increased astronomically even in the 20 years I've been in practice. Insurance forms, sick notes, special government forms to get pharmacare to cover certain medications, pension applications. The complexity of patients and their care and the medical legal requirements of the current age require far more detailed charting than previous generations of doctors. The charts of the physician whose practice I took on often would say, cough, amoxicillin. That was it in its entirety. The college now requires that I and other family doctors like me document a complete history of the patient's symptoms, their past history, my physical exam findings, all diagnoses I considered, the advice I gave to the patient, and my management plan for every single patient I see in the day. Every lab or investigation a specialist orders gets copied to the family physician, and I have to review every single one of them and either sign off on them or decide if I need to action it. This is in addition to the labs and investigations that I myself order. Somehow this all needs to fit into 24 hours. I often say to my patients, well, I'm doing great. If you figure out how to fit 30 hours in a day, let me know, and then I'll be great, perfect. I could make it more sustainable by discharging patients from my practice, but I cannot bring myself to do that because there are no more family doctors out there to assume their care. We are all carrying more patients than we should because we care. We love what we do and we want to help. So we end up accepting just one more patient. We are asked multiple times every day to take on yet more patients that have to say no because we are human too. And there's absolutely a breaking point beyond which either patient care suffers or the doctor burns out. Yet looking in your patient's eyes as they plead for you to accept their mother, son, sister, or friend as a patient, and having to say no causes moral distress. And this is yet another reason why doctors are burning out. I have practiced in Victoria for 20 years, and I have never seen the profession in such a state of demoralization and burnout as it is currently. Doctors are giving up their practice every day. The ones still in practice are exhausted from trying to keep body and soul together while juggling their practice and their family life. Some doctors in their mid-70s are not retiring because they cannot bring themselves to leave their patients with no family doctor to take them on. Or if they do retire, rather than celebrating, they struggle with feelings of guilt and failure. If there were more family doctors, each individual in community longitudinal care, I should clarify, if there were more family doctors in community practice, each individual doctor could carry a more manageable patient panel and achieve work-life balance. Where have all the family doctors gone? Doctors with the exact same training as I have can become hospitalists, GP oncologists, surgical assistants, work in an urgent primary care center, to name only a few. I am pretty much the last generation of doctors who went into community family practice. Over the past 10 years, none of the residents I've been involved with training have chosen to go into community family medicine in BC. There are so many more attractive career options out there that pay substantially better, easily twice as much, with no overhead, little paperwork, guaranteed time off, and no need to run a business. Why would they choose community family practice? These are smart young people with huge student loan bills to pay, and they are making the smart financial decision when choosing their career path. I can't blame them. Can you? Until we make community family medicine the most attractive career option, we will continue to have a family doctor shortage. What is the way to make family medicine attractive? Give supports for overhead. Either help us with our business costs, or set up a clinic where we can come and focus on being a doctor rather than a business person and an HR manager rolled into one. We don't expect firemen to build the fire hall or teachers to pay for their schools, do we? Change the payment structure so that we are allowed to bill for all the hours spent on charting, reviewing lab results, so on and so forth. Not many people out there would apply for a job where the posting says hourly salary paid 40% of the time and the rest is pro bono. Lighten the administrative burdens of unnecessary paperwork and let us focus on what we were trained to do, building relationships with our patients and taking care of their health in the practice of medicine. That is how we can make family medicine sustainable, keep family doctors in practice, and attract new grads so that once again, everyone in BC can have a family doctor. Before I leave, I would like to share a story with you, if I may. It highlights why what we're all fighting for, a relationship with a caring family physician, is so important. I've been given permission to share Marcia's story. When I took on my current practice in 2016, it quickly became apparent that Marcia was, her complex medical problems easily made her one of the most complex patients in my practice, and quite possibly in my entire medical career. Because her issues were so complicated, I saw her on a very regular basis, and we quickly established a wonderful rapport. She would ask about my kids, and I would ask about her latest shopping exploits, or her favorite dish at the pub she might frequent with her friends for lunch. She was always the picture of composure and good humor, no matter what she was facing. She always had a kind word, and often chocolate, for everyone that she encountered. Unfortunately, Marcia developed metastatic cancer and called me in tears to say that the doctor at the hospital had given her only 2 months left to live and she would be lucky to see her next birthday. I listened to her fears and then reassured her that hope was not lost. The doctor at the hospital clearly did not understand Marcia's determination like I did, and that I expected her to blow that prognosis out of the water. She did. That was almost 3 years ago. Marcia certainly defied all medical prognoses and continued to enjoy remarkably good quality of life for the next 2 years. Throughout those 2 years, her quality of life was able to be maintained because I would work with her to keep her out of hospital whenever possible, and instead keep her at home, where she loved to be and could be showered with the love of her family. I would adjust medications to mitigate their side effects, or coordinate specialists when it seemed like the left hand didn't know what the right hand was doing. One time I called her in her cell and found out she was sitting in the emergency room. It was late in the evening. She was exhausted and still waiting to be seen. I was able to call a pharmacy, give her some advice, and manage the issue such that she didn't need to be seen in the ER but could go back home. We had an agreement that she or her attentive husband, Merv, could call or text me any time of day or night on my cell phone, and I would either address the matter over the phone or arrange to see Marcia in my office or her home within 24 hours. Sadly, though, this last year, the cancer began a steady march onwards, and it became apparent that Marcia was nearing the end of her life. As she became weaker, I would do home visits, and I was always inspired by her stoicism, courage, and grace in the face of great medical adversity. Eventually, Marcia was admitted to hospital for the final time. As her pain became more difficult to manage and her quality of life deteriorated, her kidney specialist advised her that the time had come to discontinue the dialysis that she had been on for years. The palliative care doctor advised her the time had come to discontinue dialysis, as it would make her pain easier to manage. And her pain was horrible at this point. But Marcia was not prepared to make that decision until she discussed it with her family doctor. On a supportive visit to the hospital, I sat at Marcia's bedside with Merv and her family. We discussed dialysis, her disease, her quality of life, her beliefs. They were able to reach a decision after that visit to stop dialysis, and I'm glad to be able to report that when she passed away a little less than a week later, she was finally resting comfortably after a difficult and lengthy cancer journey. I tell this story not because I was able to explain the issues or any differently or better than the specialist, not at all, but because the trust and the mutual care that made the difference in this situation grew out of the family doctor and patient relationship. It is this intangible trust and relationship that makes all the difference to me as a family doctor, for whom it is an incredible and humbling privilege to walk alongside my patients through all the phases of their life journey, and to patients who deserve a family doctor who knows and cares about them and their health. Everyone deserves a family doctor. Thank you.
Thank you so much, Jennifer. That was beautiful. I'd like to invite Sharman back up to share another story with us. We hope that this story will encourage everyone to take action on this crisis. By simply signing up for a lawn sign to place in your yard, you can share a message with your friends, family, and neighbors, as well as anyone who passes by on your street. We found that our lawn signs have been instrumental in spreading the word about our campaign. We do have a lawn sign-up sheet over here. You can also opt in to be on our email mailing list, which is very irregular and just has the very bullet points of what our campaign is doing. And there's a lawn sign out on that chair if you want to see what it will look like in your yard. It's very beautiful.
Before I start reading, I'd like to say I really appreciated Dr. Lush's story. We didn't get together deciding how we would speak. I just chose this one independently, but it reflects the other side of what she was saying. And I warn you right now, I've read it out to my husband 3 times, and each time I've cried. So I'll try my best. Again, this came on the website from a very distressed BC citizen without a family doctor. My mother-in-law had a history of cancer and was supposed to get regular screenings, but it never happened because there was no GP to arrange it. Recently, she started feeling ill, but walk-in clinics who didn't understand her complex history were unable to diagnose her. Finally, she went to the ER after she started coughing up blood. They diagnosed her with advanced lung cancer, which had already spread to her brain and liver. She died within a month. My wife did her best to coordinate her mum's care during her last days because there was no GP to do it. Our hearts are broken. My wife has lost her mum, and my young children have lost their beloved Lana. A GP would have almost certainly found the cancer sooner and may have saved or at least prolonged her life. They certainly would have made her last days easier and relieved my wife from the stress of trying to play doctor while preparing for the loss of her mum. Politicians, enough with the Band-Aid solutions. The shortage is killing people. Train more doctors. Pay family doctors a decent wage and create a model of family medicine that is attractive to new doctors.
Thank you, Sharman, for sharing that. When I read that story, I knew that there was no chance I'd be able to read that, so that was very well done. Our next speaker and our last speaker is Dr. Lana Wicentovich. In addition to being a mother, spouse, and Victoria resident, she is a dedicated family physician. Lana and her family moved to Victoria from southern Alberta just over a year ago. Lana will now share her experience working as a family physician in British Columbia after spending the majority of her career working in other provinces. Her unique perspective gives us greater insight into why family medicine in BC is particularly challenging in comparison to other provinces.
I think I'm at the right height for this microphone, unlike my colleague, Dr. Lush. Thank you, Alexis. Good afternoon, friends and concerned citizens. It is truly an incredible honor to be able to speak with you all today. Thank you for taking this time out of your schedules, and I do look forward to engaging and the deep sharing as we work to understand this issue at hand. I just want to start out by saying we don't know what we don't know, and we can't find what we don't know if we don't look. So, because of family circumstances, I moved to this incredibly beautiful, breathtakingly beautiful province just over a year ago. My husband's non-medical work brought our family out west, and I was open to the change because I work in a profession that is needed everywhere. I am a family doctor. I have close to 20 years of experience in this field. I have a variety of skills and expertise that I thought I could utilize in a variety of different practice settings and communities. There's no other way to cut it, but it is hard to close a practice of 15 years. I can't even fathom what it would be like when you've had a practice for 40 years. But even after 15 years of relationships, so much hard work and energy went into the care of my patients and the work that my group practice did in developing and supporting a medical home for all of our patients. Alongside this feeling of loss, as I told everybody I was leaving, I was overcome with incredible gratitude for the beauty, the struggles, the love, the heartache, the joy that I shared with my patients. My patients and I walked so many paths together: births, unexpected loss, death, illness, cancer, broken bones, hospitalizations, transition to assisted living, chronic disease, and palliative care. And you get the idea. We all know that. And illness, really, the beauty of it is that not the beauty of illness, but it presents first in the family doctor's office often. I mean, it's a real opportunity based on that long relationship to be able to find and diagnose and manage issues early. Family doctors are dedicated to their patients, and there's countless of examples which we've just even heard today. It's the long-term, that longitudinal relationship that strengthens our abilities to be expert clinicians, scientists, therapists, diagnosticians, and our practice touches the whole breadth of medicine. It's expertise in the general, expertise in navigating illness in the individual, the family, and the community. Before moving to Victoria, I did live in a small city of 100,000 people, and I just wanted to share a little bit about my practice that I left. I was an independent group practice. At about 8 or 9 years ago, I signed into a regional primary care network. I practiced office-based, comprehensive community medicine. I did have years when I looked after patients in the hospital. I continued to look after my long-term patients in the community. I took learners into my practice. I covered sexual assault call, a variety of different things. But at the heart of my endeavors was my private practice. Being part of a primary care network allowed my private practice to up-level the care for my patients, our community, and our entire health region. The philosophy of the network was to support community physicians in building and enhancing medical teams. Any doctor could be part of our network, and funding followed, not physicians, but patients that were attached to doctors. To be eligible for funding, I had to meet certain business requirements. I had to staff my office like a general family doctor would. It wasn't just money to offset all of that, but I could pay for staffing in my office with the fee-for-service system that I worked in. And once additional funds flowed into the practice via my patients, my colleagues and I determined the allocation. It was stipulated that the majority of this money needed to go towards value-added staffing. And that could be anything: nurse practitioners, registered nurses, psychologists, exercise therapists, counselors, pharmacists. Really, the sky was the limit, but it gave us the flexibility with the deep understanding of the patients that were actually in our practice to up-level their care. And the patient-physician relationship remained at the heart of this medical home. And it became much richer for the patients to have this care supported by other team members. All those team members have expertise unique to them that supports patients in their healthcare journey. It was important. But whether I was part of a group or practicing independently, this additional support came via patients, for every patient that was attached to a family doctor. And the goal really was to attach patients to doctors. When I moved away, my medical home was staffed with licensed practical nurses, registered nurses, a clinical pharmacist, mental health counselors a little bit of the time. We did on-site programming for obesity management, diabetes management. We set up a hospital discharge follow-up programs that we as a team developed in addition to our usual office support staff, reception, MOA, a referral booking clerk, transcription services, and an office manager. Regionally, our primary care network hired data analysts. This is where you don't know what you don't know comes in, to track data regularly and to report out to every doctor key indicators. How many patients in my practice had their blood pressure checked in the last year? How many were screened for cancers? How many were actually meeting the targets set out by the Canadian Task Force of Preventative Health? With this data, my team could work to improve, measure, change, measure again, and strive to continually enhance the care of our patients overall. Studies have been done and continue to show that attachment matters. Patients who see only their primary care physician and the team around that physician have better mortality and morbidity outcomes. They are less sick and they don't die as often. It's a rare event when one of my patients needed to seek care at a walk-in clinic. And how did I know that? Because we also track that data. So we followed visit data on our patients and combed through how many patients in our practice were attending the ER, other clinics in the community, walk-in clinics. And we asked ourselves, like, why are the patients going there and what can we do? Are these appropriate visits, or is there something that we can do to keep people looked after? We aimed for yes. And develop strategies when the answer was no. Patients do need to go to urgent care sometimes. They do need to go to emergency at times, and we want those people that need to be there. And for their care to be expedited when we can keep the people that don't need to be there looked after in the community. I was surprised, however, to learn when I moved here that my professional journey was going to take a major turn. That my journey, instead of being grounded in a new family practice, would have me deeply invested in BC healthcare matters. That my energy would feel most aligned in supporting the actions, voice, and determination of one BC citizen, Camille, Currie. I'll share how I got here quickly. When I moved, a dear friend that I did residency with in Nova Scotia and a colleague of mine said, Lana, just locum first. Locuming means being a substitute doctor, like a substitute teacher. She said, just give yourself a little bit of time to experience working in the system before committing to anything long term. I'd never locumed in the last 20 years of my practice. So after my first couple of weeks of practice, I did start to feel a little uneasy. By 6 months, I came to the surprising decision that I needed to step away from active practice and really explore what I wanted to do and how I could be of most value. This is not because I was not inspired by amazing, passionate, intelligent, hardworking physicians here, many of whom were working 60 plus hours a week to keep practices afloat. And it was not because there was ample gratitude sent my way as I was seeing patients and questions. Are you staying? Are you going to take more patients? Can you take? But it was because after years of being compensated in the system for the comprehensive care I provided and the team I curated, I was spending so many hours uncompensated. And I couldn't reconcile this within myself and how I valued my own self-worth and expertise for the job I was doing. Because so much of what I was doing was undervalued, I set up a spreadsheet. I worked through budget numbers. What would I have to do to be able to see the number of patients to create the team that I would like to hire to be able to up-level the care? And the numbers, they just don't match. But the work, it needs to be done, and the care, it has to be delivered. And because family doctors are driven to high personal and professional standards, we ensure that everything that needs to be done is done regardless. And there are many jobs that need to be done in the context of a full-scope family medicine office. So because all these jobs would need to be done, and I would not have the staff, complement of staff, or be able to afford that staff, I would be spending more time working, but actually less time practicing medicine. I also couldn't reconcile that when I was organized and efficient and could accomplish more than one thing in a single visit, the system's set up that you have to take cut rollbacks, 50% discounts if you're doing more than one thing in a visit. And a lot of things were just not billable at all. And all of that just goes to not support the office and what we could do. So it was going to push me towards one problem, one visit medicine. And that's not the way I envisioned the kind of family physician that I am or want to continue to be. So after some deep discussion with my husband, we said, it's okay to step back and take a pause and a deep breath. If I committed to a practice, my willingness to work would reinforce a flawed compensation model. I would suffer in the time that was going to be taken away from my own personal interests outside of medicine, as well as the time would be taken away from my 3 teenage sons. And that time we all know is very fleeting with our family. So here I am speaking today and trying to lend my support to a louder voice and a movement. Because the thing is you don't know what you don't know about your health. And close to 1 million people in BC are having a hard time figuring out what they don't know, and perhaps don't even know that they should be looking. One example from my own practice was a patient I saw early in my career, presented to me with a normal mammogram. We might think, well, as long as I can get to mammogram screening, my breast cancer screening, that's good. But based on my understanding, deep knowledge of the family history, I decided it was actually important to follow that mammogram up with a clinical exam. And I found a lump that the mammogram had missed. And she did not know what she did not know. But I knew to look for that and change the direction of her journey. We have all seen stories from our local emergency physician colleagues, physicians who do spend 3 to 5 years training after medical school to become experts in everything acute, life-threatening, urgent. But they are also, in their practices now, being forced to do patchwork primary care medicine. And this is expensive. Accessing care in a hospital costs so much more than in a community. And honestly, it's not the emergency doctor's area of expertise either. And they're not set up to follow chronic disease when the patient leaves. And they are starting to send out alarm bells of metastatic cancer presenting in Emerge. My question is how long do those patients wonder about symptoms at home, but couldn't find a doctor to see them or follow them over time to pick up the first signs of illness of that cancer to make an earlier, or have the potential to make an earlier diagnosis? Just this week, we read in the Times columnist examples of a local cardiologist writing an editorial because she cannot discharge patients back to their family doctor when they have no doctors. So they are left managing the chronic care, or sending the patients off to patchwork episodic care on their own. If those specialists are managing the care of what a family doctor is actually the expert in, that means less patients get access to that specialist for that very specialized care. I believe at the core of my being that everyone in British Columbia, in Canada, deserves a family doctor. This is at the heart of universal health care. The World Health Organization provides this definition for universal health care. It means that all people have access to the health services they need when and where they need them without financial hardship. Now, we may not have to worry about the financial hardship here in Canada, but for too many people, the access is completely lost. And where do you go when there is nowhere else to turn? Letting almost 1 million people languish in BC without attached longitudinal care, not knowing what they don't know, is not okay. People are falling through the cracks. And for those people that fall through the cracks, it's really hard to speak out if you're really sick. We must demand that the government invests in family doctors in such a way that physicians spend their time practicing medicine as a physician at their highest level. They must be compensated as skilled doctors, expert professionals. I'm going to ask you all a question. Do you, right now, have access to a thriving family doctor? A doctor who can run their practice, working sometimes intense but fair and reasonable hours so they can remain connected to their families, their outside passions, and their life. Because when they can do that, they show up for their patients as the best versions of themselves and the time they have with you. If you do, this is awesome, because you know that this exists and what it feels like, and it can be done. You know that you are cared for and where to turn to for help when you need it. I think Dr. Lush just shared an amazing example of exactly that. You know what quality community care is, and what it feels like to be secure in the knowledge that you do have a family doctor. You, those people, need to be the voice that demands this quality of care for all the citizens of our province. And if you do not have this experience or cannot find a family doctor, or see your family doctor suffering, working endless hours to keep their practices afloat, with increasing wait times to access their care, we have to ask why. Where in the administration and government decisions and policies, what's gotten us here? Why are almost 1 million people in this province being left without a doctor to call their own? We know that there's no absolute timeline for disease to present. There's no crystal ball for health. Whether young or old, we all need to be able to call on our own family doctor when we need it. It's our duty as citizens of BC to demand some accountability, because I don't think talking points, excuses, or rehashing of historical mistakes is going to cut it anymore. As citizens, and through the work of this group, we must demand immediate action with honest and robust investment made as directly as possible to the experts in primary care, family physicians, to ensure that every citizen who wants to be cared for and have their health supported by a family physician can.
Thank you, Lana. That was wonderful. So we're going to end the speaking portion of our meeting with one last story from Sharman, one quick story. If you feel passionate about this story or any other story you've heard here tonight, I encourage you to write to your MLA or the Premier, Prime Minister.
And him too.
Yeah, and him too. The Premier, the Minister of Health. I have it on very good authority that the MLA for this riding, MLA Murray Rankin, wants to hear from all of his constituents about how this crisis is affecting them. So, without further ado, here's Sharman, and then we'll have Camille wrap us up, and then we'll do a question period.
Thank you, Alexis. One short one. This was, I think this was put on the website. I've lived here for 16 years. I am celiac with bowel cancer in my family. We couldn't find a family doctor for my young daughter. My daughter died of bowel cancer just after her 18th birthday. If she'd been seen regularly, perhaps she would still be alive. We have in this province a healthcare crisis. I've lived in third world countries with much better access to doctors. Please help us. Thank you.
Thank you very much for all of our speakers today. You did fabulous, and you raised a lot of emotion here today. And I think I've probably expressed the most emotion here today than I have on all of my interviews, but don't worry, I won't drop the F-bomb. Unlike someone else. Because instead, I'm going to harness my energy, my emotions, and put this into our calls for action, for positive change that we all need and deserve. So I hope that I'll be able to see all of you out at our rally on May 19th from 11 a.m. to 1 p.m., standing shoulder to shoulder with me and my group, all the medical professionals that will be there, all the other residents and citizens of British Columbia that will be there, and let us show them. Let us show them that this is not acceptable, and we are not going to sit around and wait. We need immediate action. Thank you all very much for coming today. So we'd just like to open it up now that if there are any questions, and we'll kind of try to direct to the correct individual that might be able to provide you with an answer. So at the back.
Yes, my name is Laura Camille. I just come to, I've been in Victoria just over 1 year. We moved here April 6th of last year, and my husband and I were positively shocked to discover you couldn't find a family doctor. We had a wonderful doctor in Calgary. Her name is Alexis Thompson, for those of you who might be thinking about going back. She's absolutely outstanding. She's down in the Bonus area clinic there, and she's far none fantastic. What I don't comprehend is, and maybe some of you who were in oil and gas can tell me this, but Alberta is right beside BC. They have a wonderful system. We don't have to go to the United States. Well, that would be a bad country to go to. We don't have to go anywhere else, for an example. We've got one right next door. Why is the BC healthcare system not a replica of our excellent Alberta system? And is it because Alberta has oil and gas? We pay so many taxes here, and we pay all these taxes. Where else is this money going to? I don't comprehend. Now I just understand that Premier Hogan was recovering. Does he have a family doctor? Does he have access to all the specialists? Somehow I suspect he does. And so I don't understand where the money. Where is the breakdown? How is this possible? How is this even been allowed to happen?
Yeah. So just to repeat for our online viewers, I'll try to recap your question quickly, which was that we do have our neighboring province, Alberta, that has, in comparison, quite a thriving healthcare system. And so why is it that British Columbia cannot replicate some of what Alberta has succeeded at? And also the question raised, what was the other second part? That's the question? Okay.
My friends back home tell me you can drive down Sarcee Trail, there are doctors advertising that they want more patients. They're looking for patients.
So there are doctors in Alberta that are advertising for patients. It's not that difficult to find one is the question.
Friends of mine in the Okanagan, they shut their Alberta Health Plan. They drive back to Edmonton, stay for 2 weeks, get all this testing and everything done, drive back to the Okanagan. I don't even think that's legal, but that's where they can get all their help because they can't find anybody. It's mind blowing.
It is.
So I guess the question is, why don't we have an Alberta system here in BC when they're just next door?
Good point.
I think we need a politician.
So I guess I will take that question, and based on the research I've done, as well as having been an Alberta resident myself within the last decade, I do concur that the services we were receiving as a family in Alberta were far exceeding what we're able to receive here in British Columbia. And from what we have heard, this goes back to much of the issue that the BC government does not collaborate appropriately with the health associations as well as the medical professionals in the same way that they have done in Alberta to create, as Lana suggested, effective working primary care networks. The other thing is that BC has held several conventions where they have even brought in individuals from Alberta to gather information, gather expertise, for example, on what's called EMR. So that's the electronic system that's used for collecting all of our data. And they brought in people from Alberta, as Alberta has what's called the Netcare system that works very well, very consistently. Held a convention, shared information, found out how they could implement it in BC. And the BC government decided instead to hand out 6 different options that the province of British Columbia within their health authorities could choose to implement. So I don't have the exact answer to your question. I have the same question as you. Why must we continue to reinvent the wheel in British Columbia? And why can our government not take some tried and true successes and implement them here? Ontario has several of them themselves.
It would be very easy to do. We have a model right next door.
Is there another question? Sorry, just behind you there.
Stand up, please.
Number one, with the doctors, I understand from various people, politicians and so on that talk about this, that one of the problems with the doctors is that they don't look at that colleges, physicians and surgeons is reluctant to license people from abroad or nurses who have been trained in other countries, and they have to come here and run through very expensive hoops in order to get licensed and able to practice. And secondly, I would like to know what your organisation, what they have in mind in terms of actual approaching people. I know you're very young, and your organisation is very young, and I know that you haven't had time to do a lot except gather support. So I'm not criticising you. It's just that what you have in mind in terms of approaching politicians before the next election and this sort of thing. Because Mr. Dick seems to be well-intentioned and does work hard. I think he has worked hard in COVID, especially, but I think he's perhaps, he only has 24 hours a day as well. So it's not all criticism. I think you have to give some to people. But I just wondered what you had in mind in terms of action to the people who have the opportunity to do something. And Horgan was on CBC this morning and said it's all because they're not getting transfer payments and so on. So what's happening about that?
So about 3 parts to the question. So the first one being regarding access for international physicians and nurses to come and practice within British Columbia more easily. So again, I will let one of my colleagues here step up if they'd like to provide more expertise on the actual field. But the one thing that we do always kind of want to highlight for people is we're showing you and describing today a system that is not functioning, a system that is not providing. And so to suggest that one of our solutions might be to bring in foreign doctors and foreign nurses, it begs to question whether they would even want to come here, considering they would face the same struggles as the nurses and doctors that are currently working in this system. So once again, adding more bodies, we definitely will need more bodies. There are retiring physicians. There's no doubt about that, and we fully support easing international processes to get more people into Canada. But this crisis right now won't be solved with that, because if we don't create a better base structure to support the individuals that we want to allow to come into our country, we'll be no further ahead. They will just simply move off to other provinces, or they will choose the more lucrative positions as well, and it won't help support our family physician need. Is there anything to add to that? And sorry, there was a second part though. Yep. And now I just forgot. Oh, right. So yeah, what are our efforts being made with politicians? So we have met with several MLAs from every party. And the only individuals we haven't met with yet is Premier Horgan, who happens to actually be the MLA for my district, and I have made several requests to meet with him. So I'm eagerly anticipating a response from him one of these days that he will come and meet with me as my MLA and as my premier, and I think that is a conversation that should happen sooner rather than later. As for Adrian Dix, I have not heard anything from him either. He has been CC'd on all of our communication, but to this point we have only received some of the emails that some of you have already as well. So we do continue to try to open a door in communication with MLAs and with the Premier and with the Health Ministry, and we are an open door. We're happy to talk anytime.
I'm Dr. Toga. I'm a retired pediatrician, and I've been living in Victoria now for over 25 years. Thank you for this time. I'm a retired pediatrician, physician, and now teaching at UBC Faculty of Medicine. Like everybody else, I need a family doctor. So I'm with you, but my journey allowed me to just express my journey. Okay, so I practice and train in the U.S. and Canada, practice in Manitoba and Kentucky and Washington, mostly underserved. It's called HIPSA, it means Health Professional Shortage Area. So I was in the Appalachian Mountains of Kentucky. 90% of the physicians there are from all over the world. So just to give you some stats, if all the Filipino nurses in the U.S. resign today, 50% of American hospitals will close down. So that's just the extent. So I'm glad that nurses now, I think from Finland or Sweden, are being fast-tracked to come help us here. And the lady who asked about foreign doctors, I'm one, so I know that journey very well. There's about 13,000 international medical graduates in Canada, 5,000 alone in Manitoba, where I practice, and I really felt for them. I was just lucky that I was able to practice in self-care. By the way, each government, each province has a different mandate in producing their licensing. So I was able to practice right away, maybe after a year paperwork in Manitoba. So I went up for 6-7 years. Yes, I was able to practice in Manitoba for about 6 to 7 years. No questions asked, for my licensing and credentials, so I'm very grateful. But when I went back to Victoria because of family issues, the licensing requirement in BC was so stringent. So after 2 years that I was not able to practice, I lost the window to practice. Imagine I have 15 years, I have 8 years of pediatric training, I'm an endocrinologist, so I lost all my skills. But I'm not ungrateful. I'm very grateful to be here. My wife's Canadian, so much to be thankful here, especially in Oak Bay and with Monterey Rex. And so let me just be brief. So I have 3 recommendations, okay? Either short-term, long-term. Consider hiring, number 1, consider hiring more international medical graduates. How do we fast-track them? It's not an easy solution. The BC now government is doing an associate physician track. So it's quite a detailed process, but you could look into that. Number 2 recommendation, walk-in clinics. I've worked in urgent care clinic in Winnipeg Children's Hospital, hospital-based practice in small town, USA, and fantastic remuneration. What I was making in self-care, I couldn't even pay my secretary because there was not enough patient load for me to compete with the only game in town, a pediatrician practicing for over 30 years. So I had to leave and go back to the US. So that's exactly the number 1 problem, remuneration. My lawyer charges more for billable time, looking into when I apply for my citizenship. So you could just see the disparity in pay. Number 2, walk-in clinics. Yes, we do rely on it because they are escape valve, especially now. We don't have family doctors. John, I'll not give this is an article from Dr. Marcus, Toronto, family doctor. And it says the 10 commandments of navigating walk-in clinics. So please share that. So they're still useful and do maintain a good relationship. Because I had to when I was dealing, especially with babies, with children. Okay, I worried mom or grandpa. And also, I think this is a time to reconsider revising our treatment model. For the last 5-10 years, I've been using acupuncture, traditional Chinese medicine. I do Qigong here, which is total body medicine. There's a lot of alternative and complementary therapy. My family physician in Richmond is going to retire. He's 8 years old, so we still have a relationship by by phone, and he's very open to my using complementary and alternative therapies. When I had an injured, fractured kneecap joint, my trigger-happy surgeon just said, Mario, you're not going to get your leg straight without surgery. I disagree. Because when I look at the evidence base, that you can be rehabilitated with like an intensive physiotherapy. So, and last recommendation is I think we should be promoting a more holistic naturopathic lifestyle, natural supplements, but also coordinate with your family doctor so you have a good collaboration. Now, therapists or psychotherapists now might be assigned to doctors' offices to streamline the referral because we need counselors, therapists. Psychiatrists know that the wait is 6 months. So thank you for just giving me this chance.
Camille, first of all, I want to say thank you. I know you're spending tremendous hours in this. You have a young family, and it only takes that spark to get this moving. So thank you. And I also want to extend my gratitude to the physicians and all the healthcare workers who have been through hell these last few years. It's been an unthankful process. It seems to me, and I've been here for 2 years in Victoria, I love the city. I come from Ontario, and I'm trying desperately to understand the system here. My questions, first of all, I don't understand Alberta's, but I do know that there's oil money probably there, but my big question is, where is the money coming from? I'm told that the federal transfers are the same for Alberta as it would be for BC. So what is Alberta doing? Is there money coming from the government from other sources? Because I don't believe you pay taxes, provincial taxes, do you? In Alberta?
No.
BC, I know we do. So that's my question, is where's the money coming from? And in BC, because I've never had a family doctor here yet, I've done cold calls, I've called Island Health, I've asked if they would set up a wait list for Victoria, and they won't, and I have had no response in that. So I don't think they truly know how serious it is here. But in BC and in Alberta, I'd like to ask is, are physicians allowed to charge an annual fee of their patients that is optional, but if they can't afford to pay it? In Ontario, we paid an annual fee if we chose for services that were not covered by the government. So it would be based on an individual or a family basis, and this would cover for a lot of that non-billable, so writing the insurance reports, doctor's notes, and there was a whole list we got every year. And you could look at the list and say, well, I don't use those services, so I don't need to pay it. Or you could say, yes, I want to support my doctor, I'm going to pay it, and I have that ability to pay. So is that allowed in BC? No. Okay, there may be
What's the
quick
doctor
fix.
over there doing at $500 a month then? Is a GP doing it?
Pardon me?
Well, right here in
That's a
Oak Bay.
pretty high annual fee. Like
I know,
I'm
but
paying
it's
now.
the nose of the camel. It's
No, I
here.
know, but that would be a quick fix. If it's optional, like I really get nervous about this because I've actually said to my daughter, who's also in BC, I'm prepared to pay for health care if I have to, but that is creating a two-tier process that I do not support. But if there are those that can afford to pay an annual fee that could help support our doctors, that might be an interim solution. The other thing I really want to understand is I don't believe government is the solution. I don't believe they're going to come up with answers. And I asked Island Health if they would create a committee with people like yourself, Camille, and physicians, but informed patients, informed citizens to sit down and think big. Like we have got over in Ireland, just as an example, I believe there are 5 medical schools, 4 or 5, that are full of young Canadian citizens that could not get into Canadian medical schools. Why don't we get a way, fix the system on pay, and get a way to get them here in Canada and we will forgive their debt over 5 or 10 years. We will take their debt and say, we will pay for this debt if you will give us 5 to 10 years. You can have it on a sliding scale. If they leave sooner, then they pick up the balance of the debt. We can work with financial institutions and work with the government and forget that debt and get the doctors here and get them into group practices. So I think we need to get some big thinking going on out here.
Thank you.
So I'll just answer your first part about BC and Alberta. The one thing I can tell you is that I've done the metrics. I've gotten all the data from Stats Canada and from the individual provinces and calculated it out on a per capita rate. And BC and Alberta compare almost exactly in what our health ministry funding is. So that's important to know, right? Because you're asking me, like, where does their money come from? They must have more money. So I don't know where the money comes from, but the money they're using for their health ministry is nearly exactly the same amount that we have allocated to our health ministry. And not only that, as you suggested, I also did the math on the health transfers, and the health transfers to BC and Alberta are the exact same because it's based on per capita number of citizens within. So it's something to consider, right? You raise a good question, and it's something to really consider that we have the same numbers on the books. So what's going so different, right? I'll just let Sharma answer to the last part of it.
You mentioned about getting a group together to advise the government, and I don't have as much detail as Camille do. I stand on the street and hand out leaflets, and people come and stop and tell us things. And one of the first times I did that up in Oak Bay, a man stopped and he said he was a retired specialist. He didn't want to be named, and he didn't want to have this story written down on the website because I asked him if he would do that, but I can tell it to you verbally. And he was on the advisory commission, and I don't know whether it was Doctors of BC, I don't know. At that point, I was fairly naive, and I didn't know half of what I know now. So I can't remember what he was, but he was on an advisory committee for the Ministry of Health, how to improve our healthcare. He was on it for 5 years. He retired probably a couple of years ago, and I'm not sure exactly which 5-year period he was in, but it doesn't really matter. It doesn't really matter what government was in power. And he said he had these meetings, they took up a lot of time, he spent 5 years, everyone made really good suggestions, they planned out plans, they worked really hard, and the government went their own way, their own path, and did not listen or start any of the programs or suggestions or do anything. It was strictly, I personally think it will make you feel better, will make you feel like you're trying to tell us what to do, you'll make you feel that we're going to listen to you, but we'll open a UPCC and boy, will that be a good photo op. Look, I'm cutting a ribbon. So that's my answer to that.
Very good.
Yeah, and I would just extend on that for all the communications I've had with a variety of different levels of individuals in the medical field now. There are a ton of committees that do currently exist that have citizens on them, that have medical practitioners on them, that have government officials, and at this point, I don't know if it's how they're. Well, I do know what it is that they're developing great information that's going nowhere.
Yes. Yeah.
That's the honest truth. So that's part of the lack of transparency, right? Yeah. Steve?
I don't think it's right. I'm Steve Markison, and I was a member of the Legislative Assembly for Victoria from 1996 to 2001. I'm entering my 70th year now, and it's the first time in my life that I don't have a family doctor. And in 1996, it seemed that this was not an issue. People had family doctors. In 2001, the government came in and called it a new era, and we moved from a variety of regional decisions-based decisions being made regionally regarding healthcare to regional health authorities. For us, it's Island Health, Fraser Health, Interior Health, and so on. And I would submit to you and to the panel that the focus in delivering health care. Governments get their money from the federal government for health care transfer payments. The allocation of those resources is used to be up to the provincial government. Now it is up to largely health authorities. And health authorities have made a huge commitment and focus and a prioritization of putting that money into acute care, to the detriment, in my view, of primary care. That's what's happened. That's why we see doctors not getting the support of family physicians, not getting the support they need. In my view, it's ludicrous what has occurred. The solution, in my view, is to put doctors on salary, good salaries, to be physicians, take the administrative responsibilities that are being visited upon them, the reporting mechanisms, and all the rest of it, and let other people deal with those issues. It doesn't make any sense. If you hire an electrician, you don't pay the electrician's wages to wash dishes and wash walls and sweep floors. You want a physician to be able, a family physician, to be able to practice family doctoring and family care. So I'm really pleased this group has come together. This is very necessary. It's very timely. It is precisely what needs to be done in our community and in our province, and in fact across Canada. And one final point, and don't be too controversial, but Alberta is not the panacea here. 1 in 5 people in Alberta do not have family physicians. Those people in Alberta, the 4 out of the 5 that do, good for them. But there's 1 in 5 that don't. And it is ludicrous that we have a situation here in British Columbia where 1 million British Columbians do not have family physicians. And 4 million people in the rest of Canada don't. We are we're into such a serious problem and a serious crisis that this movement here that's beginning, and thank you for bringing this all together, is so necessary, so crucial. And if you believe that we need to do something here to get things back on track, have government put the focus back on family physicians, then you need to be at that rally, and you need to encourage all of your friends, your family, your neighbors, everyone, whether they have a physician or not. They need to attend. We need to show the government that there needs to be a change here. The focus has to go back on families, primary care, and the funding needs to get there to support those people that deliver the services that we all so desperately need for our
Thank you for those words. I did want to just make one comment about a switch of the model of how physicians are compensated. In my heart of hearts, it's not a model problem. It's not like you're fee-for-service and therefore you can't run a business. I'm fully capable of doing it, whatever the funding model is. At the heart of the matter is that there's just not enough funding to support a business. So be careful saying, well, if doctors were paid a salary, all the problems would go away. Doctors just need to be paid compensated so that they can run and operationalize their business. There are some doctors that will gravitate to a salary. There are other doctors that are more suited to fee-for-service. And I think the key is let's try to get every type of family doctor working up to their highest capabilities.
I've done family care through my families all my life. In the 70s and 80s and 90s, we had a shortage of doctors on Pender Island, and I applied. They were asking scientists in the 80s to come back in and be trained as GPs, and I applied. At that time, actually doctors period, and we couldn't keep a doctor on Pender Island. Then a lady came in and had a family and stayed until she burned out. That was in the news. I saw all the financial cuts starting at least by 1990 in our healthcare system. First, the nurses were hit, then the doctors were hit. They went to the States. Some came back. They didn't like the style of medicine or whatever down there.
saw the huge changes in 2001. And in my lifetime, the city has gone from since 1965 when I came back, our population has quadrupled. We have fewer beds to our hospitals now. Mr. Dix talks about numbers. He said our hospital beds are 155% over capacity, as it is. And we never hear about how many patients can a doctor handle, the doctor-to-patient ratio, so they don't burn out. And I've seen the paybook for the doctors from the specialists down about 20 years ago. And I want to know, I know a lot of doctors gave up and went back into the hospitals to do a 9-to-5 job, get a steady pay with steady hours so they can have a family life. My doctor's 74. A lot of my classmates are doctors. They're retired now. Mine is still practicing, as well known. The 20% rule is a Pareto rule when you're looking at computer modeling and systems management analysis. My background is as a physicist and as a modeling for all scientific and engineering applications, managing these systems. I look at it as a systems problem. I had a dentist, he needed $100,000 to do a 1-year recertification at UBC just to rubber stamp it when he came in from the Philippines. He could have got it done in Quebec for free and given his time over for that free certification. He didn't want to go to Quebec, so he was working in a car wash. And that was around 20 years ago. So what is the patient ratio to doctor that would work? If we have 6,800 doctors in that paybook I saw, and only 3,100 are practicing, what are the other ones doing other than being in the hospitals? If we have enough money, and this goes over the whole Commonwealth system, you look at the McKinsey reports on how healthcare is run around the world, per patient, etc. I never see how many patients per bed in the hospitals. I never see how many patients is an ideal model per doctor. So we have an ideal number of hospital beds, and we have a ideal number of doctors. High tech has changed things on how they do medicine in the hospital, so maybe they can put more people through. But I know from what happened to my dad and my mom, they weren't getting the care they needed. The Premier apologized for what happened in my father's death. It was a medical mistake. My mother, I have been through appalling conditions with her care in the last year or two. 20 years ago, when she collapsed with her heart stopping, burned out caregiver, and he was dying, Dad was dying. I don't need another apology from Premier on my mother's death. I've had enough of this. I wrote this to the TC. They were appalled. They'd had parents go through the kinds of things I've gone through. If it's not about the money, it's got to be about the politics. It's one or the other. We're not getting the whole story here. We need more hospital beds. We need decent numbers of doctor per patient ratio. We're not getting those numbers. Dix is only giving out some of the numbers. And when you look at the Commonwealth programs and how they go back to London and world economics on handling all these systemic problems, then you get the picture. And we've been cutting our finance. The doctors who have the nerve, if they're retired and write into the paper, they've been cutting. They cut our finances for medical care by 1980 in half. This is our own money going to Ottawa and coming back to us. And Ottawa cut the money by 1980. I saw the cuts in 1990. What are the ideal patient ratios for enough, so we have enough GPs and enough beds in our hospitals to do things properly? So the ambulance system and the fire trucks don't tell me to send my mother to the hospital 5 times, get sent home until she finally has 5 strokes in one day because the hospital keeps sending her home.
I'm not sure that any of us here have the answer to what you're looking for necessarily, because that is, that is questions that we have for the government as well. You know, as you've suggested, there is much data that is not being released to us. All we hear about are the perfect numbers that sound great, like the UPCCs have seen 1 million citizens since their inception, and we have brought in 600 new FTEs, he loves to say. But he hasn't brought in 600 new doctors. He has trained 600 new doctors in the province. And once again, we don't know how many have remained. So unfortunately, we don't have an answer for you on that. I do feel your concern, and we definitely share it. And this is part of the need for more transparency from this government. But I will let Dr. Lush.
I will do my best to gather my thoughts quickly because I have thoughts about several things that have been said. I will do my best to gather my thoughts. I have I have thoughts about lots of what people have said, so I apologize in advance if I sound a bit scattered. First of all, I am sorry for your experience because, you know, your mom going through that and being discharged because the emergency rooms are overcrowded and they're pushing people out. It's unacceptable. It is absolutely unacceptable. And your mom deserves a family doctor to...
I still have one. He's 74.
He needs to retire, and your mom deserves a younger family doctor. But, you know, it's a domino effect. So the family doctor crisis is meaning more people are going to go to the emergency room for their primary care, which means the emergency rooms are flooded with people. I had a patient that actually was quite rightly in the emergency room for a hypertensive crisis. She could have stroked out. Her blood pressure was way too high. It was not appropriate for me to have her in my office. She was having chest pain. And she waited for 5 hours, at which point a nurse came out and said to the waiting room, sorry, if you're not all, like if any of you think you're well enough to go home, please go home because it's going to be a very long time till you get seen. And my patient went home. Thankfully, I phoned her that evening because I knew she had not been well. And I was like, so how's it going? You know, what happened in the emergency room? And I realized she had left without being seen and had not gotten care. So then I coordinated that care and we got her blood pressure down. But the point being, she could have stroked out sitting in that emergency waiting room because the waiting room was so crowded with people seeking their primary care when they should be getting it from family doctors. So, you know, the family doctor crisis is bad now. It's going to get worse. And the emergency rooms are bad now, and they're going to get worse unless we have this immediate change that we're all lobbying for. I don't know what the appropriate doctor-patient ratio is, and I don't think anyone really does for an individual because we're not robots. We're all humans, right? So we all practice differently. You know, we all have different family circumstances. So it's really hard for me to say, you know, I carry 1,200 patients. I'm supposed to be a part-time family doctor. And, you know, to make my practice sustainable, I would probably prefer to have about 850 than 1,200. But that's also because my practice is super complex. I have a lot of, you know, diabetics, frail elderly. You know, I could easily handle 1,500 if they're all young people with, you know, well, kids, right? So it's such, there's so many variables, it's really hard to give you a number. But where we could get the numbers from would be something like net care in Alberta, where, as Dr. Wicentovich alluded to, clinics have this province-wide, not just clinics, but hospitals, pharmacies, there's this province-wide database which is a repository of information so that patients get better care. Camille has spoken to the fact that now she has to carry all the records with her so the right hand knows what the left hand is doing. But in Alberta, everybody, every caregiver would have the same information, which leads to better care for patients. We have begged for that as physicians in BC. We have begged for that, and the government is not delivering. If we had a unified EMR, we could extract data that would allow us to practice to the best of our ability. We would have quality improvement. If there were doctors that weren't giving the kind of care that everybody deserves, we could identify that and, you know, improve standards. We would also probably be able to give you a number, right? We'd be able to say, well, we have this many physicians, we have this many patients. This would be the ideal number. I do know that for a population of roughly 5 million in BC, currently 3,100 practicing as longitudinal family physicians works out to almost 1,700 patients per doctor. That's too many. That I can tell you, right? We need more doctors in longitudinal family medicine. I'm sorry, I'm not buzzing the mic. I'll try to be brief. As far as what are we doing with the monies, and because, you know, Alberta and BC are the same, I would like to speak to the fact that throwing more money at the problem does not even always necessarily translate to better care. There are systems like Finland and Australia and New Zealand where their healthcare expenditures are lower, but their care is way better, and their outcomes are better, and their access to care is better. So you have to ask, what are the inefficiencies in British Columbia? Where are these healthcare transfer payments that are identical to the province next door, which is not a panacea, but still, it's more functional. Where are the inefficiencies in our system? And I would argue that some of the inefficiencies are opening brand new, shiny, urgent primary care centers, right? That $5 million that goes into those 24 UPCCs, $5 million each, that could keep a lot of family doctors in practice, right? We're already there. We are the infrastructure. We just need supports so that we can stay in practice. We don't need to build new buildings that are going to sit empty because you don't have the doctors and the nurses and the nurse practitioners to staff them. I also among the health authorities, Mr. Orcherton, there are so many layers of duplication and inefficiencies, and you have the Fraser Health Authority doing it one way, you have the Island Health Authority doing it another. Let's get an overarching, sensible plan for delivering quality care to British Columbians. We're paying administrators instead of paying doctors and nurses. And finally, I think I just wanted to speak briefly to the fact that we have the doctors, we have the members of the public, we have the concerned citizens that want to come up with solutions. We're willing to think big outside the box ideas, but they go nowhere if you don't have collaboration. And at question period on Monday, the term collaboration was bandied about, and we were told that they're collaborating with doctors. I can tell you, they are not collaborating with doctors. We are being told what we will get. I think one of the things that makes Alberta lots more attractive for young doctors, and why you have doctors in Calgary advertising for patients, and why all the residents I train are going back to Alberta to practice instead of staying in BC. One of the things is that there's collaboration, and they have functional primary care networks there. Doctors like Dr. Wicentovich, they're given an amount of funds, and the doctors can say, okay, I have a practice that looks like this, and so it makes sense for me to create this kind of a network for my patient practice. But that's going to be different for inner city Calgary compared to rural Okotoks or rural, Grand Prairie or wherever, right? So they're leaving the funds and the planning with the doctors and the patients who know what the issues are for their community. We were told a few years ago we were going to get primary care networks in BC, and we were thrilled. We were so excited. As Camille said, we had experts come from Alberta to tell us what net care looks like. We had experts come from Alberta to tell us how PCNs were designed. We gave up hours in these planning meetings, hours we didn't really have, but because we thought this is a new future, this is going to be better care for our patients, let's develop these primary care networks so we can offer team-based care to our patients. The government likes to tout the word primary care network and team-based care in response to what they're doing for British Columbians. I can tell you, we do not have functional team-based care or primary care networks here. We were held out the shiny carrot, and we were so excited because we were going to get a primary care network. And instead of collaborating with doctors and letting us develop something functional like Alberta, we got mandated, okay, thank you for your input. Your primary care network is going to look like an urgent primary care center, and maybe we'll throw a couple mental health workers your way once in a while. So there is no collaboration, no matter what you hear on the news or the politicians are saying, there is not collaboration, and we need the government to sit down with members of the public who are desperate for access to care, which they so rightly deserve, and with doctors who are in the trenches and know where the issues lie and want to offer that care. Let's collaborate, but they're not listening.
Can you explain to me and maybe other people how it is possible that at least one family practitioner that I know of here in Oak Bay has been able to go into private practice, charging people $5,000 each, and drop his, from what I understand, he no longer has his own public practice. Is that legal? I don't know. Is it legal right now here in BC? Because I'm hearing that I know that there's one doctor who is helping. He has a similar practice for the very fragile here. I don't know if it's in both David and Victoria. And I understand there's another practice that's moving from Vancouver onto the island.
That's an unfortunate.
So I will speak to it as best I can, not being a health policy analyst or a lawyer or a physician in that kind of practice. So we as physicians are legally not allowed to bill the patient for anything that is covered by MSP. That goes against the Canada Health Act. And so any medical care, I'm told what I will be paid, and I can only bill the government that set amount. We can bill for uninsured services, so if somebody wants me to do a medical so that they can apply to become a firefighter, that's not covered under MSP. So yes, I can bill the patient for that service because it's going to be an hour of my time or whatever, right? That's allowed. So the doctors that are doing that, I'm not sure what they're selling for that. I think you're referencing, like Dr. Rosenberg, for example, charges a fee. But he and his colleagues, they go into homes and they deliver all their care in the patient's home. The patient doesn't have to come to their offices. They draw all their own blood work so that the patient doesn't have to go to Life Labs. So I think the fee for him, and it's a wonderful service that many people rely on, but I think the fee for him is explained by, it's the gas running around to the people's houses, and it's the equipment to do the blood draws and that sort of thing. There are cosmetic practices that charge about GPs, yeah. We could, I could deregister from MSP and I could make all my patients pay me for their services. But again, I'm only allowed to charge what MSP would cover. So I get confused myself, so it's no wonder that members of the public are confused.
Also, I'm not a health policy analyst, but I'm certainly learning more and more every day. But I will share one experience that I had when I came to BC and I had to attend 12 hours of Learn to Bill under the MSP system. So just to give you a sense, it's a complex system. It required 12 hours. But on my first session, we were learning about codes for billing for mental health visits. Okay, and comparing fee for fee service. I used to be able to bill in 15-minute increments for whatever the mental health issue that I was being presented with. And sometimes people come in serious crisis and they need an hour of your time and you give it because that's what is needed. And the fees in BC bill for a 20-minute visit. And I did ask my billing person educating me, well, what happens in that hour? You're paying me for 20 minutes, but I spent an hour with the patient. I was told that if I did anything else, I'd be reported to the college. It was my ethical responsibility to provide the care that the patient needed, regardless of what the payment was. And yes, of course, I'm a doctor, I'm going to do what's needed. But the assumption that you will do everything, and when we can't pay you, you will just do it anyway is not enough. And I do feel that there is this, I'm starting to understand or question, and I do not have the right answers. But we uphold universal care as like, you know what, we're all going to get the same sort of level. It's not going to be perfect, but at least it's all the same. But it's not. Some people have a family doctor and some people don't. And we're forgetting about the access piece. What would happen if we put that focus on we actually need universal access? And this is why these different ways of thinking is because if doctors felt satisfied in their practice, they would not be trying to come up with a new and improved model where they could have a business model that would allow them to possibly invest in a house, possibly pay for their kids' education, consider retirement, right? Those are goals that we want to actualize on, but we come to the workforce very delayed, often in our 30s, mid-30s for some of us, because of the length of time we spend educating ourselves to be experts for you. And so, I mean, that's happening. And that is another canary in the coal mine, which comes to the systematic problems that I think Camille is trying to shed light on.
So I know that we have other questions and comments. I know that there are two gentlemen here who have burning questions. We are so close to the end of our meeting time here. We do, however, have bchealthcarematters@gmail.com. So if you have any outstanding questions or comments or anything, I'd really encourage you to just email us. And sorry, is it what?
Just one simple question.
Okay.
I don't have family doctor.
Okay.
I put my name down forward.
Okay.
But is there any waiting list you can put your name on? I mean, as in when?
No. Right. No. So no. I mean, it depends on where you live. I do know that Saanich Peninsula and I believe the Western communities have a Island Health wait list, so you can look there. If you live in Oak Bay, you're out of luck. Luther Court opened a community health center. Again, right, no waiting list. Again, we get our hopes up, something else comes, maybe this is it, it's not it. It's time for systemic change. I think that's what everybody in this room has seen today, and that's what all of our wonderful speakers have showed us today. Before we go, Dr. Voon in the corner here has an excellent book for us. It's a guide to the emergency department. He sent me a PDF a couple of months ago, which is excellent. So I highly recommend it. It's free of charge. It says please take one per person. Very kind. Thank you so much. And thank you so much for coming today and supporting us. I'd like to thank the Monterey Rec Center for having us here today. It is so important for us. Yes, round of applause for Monterey. I am so honored that we're your first event, your first in-person event back since March 2020. I'm honored that you came. Thank you. And I want to thank every single person for sitting here with us today. It is so empowering. I know for us, we put hours and hours of our own personal time into this campaign. It is so wonderful to have everyone here and showing your support. So thank you. And I'd like to thank Camille, Sharman, Jennifer, and Lana today. I'll pass it back to Camille now.
Oh, I'm good.
Oh, okay. Thank you very much.
Just a note to our online viewers, thank you very much for participating. And if you do have any questions, you can send us an email to bchealthcarematters@gmail.com. Thank you for taking the time out of your day today. We look forward to seeing you at the rally on May 19th from 11 a.m. to 1 p.m. at the legislature grounds. Thank you, Camille.
He wants to ask you something. I want to give you about window for a quick comment. We'll get this up on the net tomorrow.